In this video, we will discuss Current Oasis 7 trial to evaluate efficacy and safety of double dose versus standard dose clopidogrel and high dose versus low dose aspirin in acute coronary syndrome patients undergoing PCI was the objective of this trial. Patients at least 18 years of age presenting with acute coronary syndrome with either ECG changes compatible with ischemia or elevated cardiac biomarkers who were scheduled to undergo angiography with a plan to perform PCI as early as possible but no later than 72 hours after randomization was the inclusion criteria. Age less than 18 years of age, use of clopidogrel within 24 hours, contraindications to clopidogrel and aspirin, presence of active bleeding or increased risk of bleeding, history of severe systemic bleeding or coagulopathy, current or planned use of oral anticoagulants, investigational treatment within the previous 30 days were some of the exclusion criteria. Now moving to the outcomes of the trial. A composite of cardiovascular death, myocardial infarction, or stroke up to day 30 was the primary outcome. Expanded composite outcome, the individual components of the primary outcome and death from any cause were the secondary outcomes. In subgroup of patients who underwent PCI, definite or probable stent thrombosis was the pre-specified secondary outcome. Major bleeding defined by pre-specified study criteria and TIMI criteria was the safety outcome. Now let's briefly go through the study design and the protocol of the trial. It was international randomized trial which was conducted between June 2006 to July 2009. A total of 25,086 patients were included in this trial, of which 17,263 patients underwent PCI. The trial had 2-by-2 factorial design. The first component of the factorial design was random assignment of clopidogrel in a double-blind fashion to either a double dose or a standard dose regime, while the second component of the factorial design was the random assignment of aspirin in an open-label fashion to either a higher dose or a lower dose regime. Now let's go through the loading and maintenance doses of clopidogrel and aspirin in these various regimes. In case of clopidogrel, a loading dose of 600 mg was given on day 1, followed by 150 mg daily for next 6 days, followed by 75 mg daily up to day 30 in case of double dose regime. While in case of standard dose regime, a loading dose of 300 mg was given on day 1, followed by 75 mg daily up to day 30. Now moving to aspirin regimes. In case of higher dose regime, a loading dose of at least 300 mg was given on day 1, followed by 300 to 325 mg daily up to day 30. In case of lower dose regime, a loading dose of at least 300 mg was given on day 1, followed by 75 to 100 mg daily up to day 30. Now moving to the statistical analysis and results. Let's first go through the outcomes at 30 days in case of clopidogrel dose regimes. The primary outcome occurred in 4.2% of the patients in double dose group compared to 4.8% patients in standard dose group. Thus, the primary outcome did not differ significantly between two dose groups. Similarly, the secondary outcomes of expanded composite outcome, individual components of the primary outcome, and death from any cause did not differ significantly between two dose groups. Now moving to the safety outcome, the rate of major bleeding defined by study criteria and TIMI criteria was nominally significant in double dose group mainly because of nominally significant rates of severe bleeding. Similarly, the rate of minor bleeding was also nominally significant in the double dose group. But the rates of CABG-related bleeding and fatal bleeding did not differ significantly between two groups. Now moving to the outcomes at 30 days in case of aspirin dose regimes. The primary outcome occurred in 4.2% patients in higher dose regime compared to 4.4% patients in lower dose regime. Similarly, the secondary outcomes, with the exception of recurrent ischemia, did not differ significantly between two treatment groups. The recurrent ischemia occurred in 0.3% of the patients in higher dose regime compared to 0.5% of the patients in lower dose regime. Thus, the p-value was nominally significant in case of recurrent ischemia with benefit observed in higher dose regime. Now moving to the safety outcomes at 30 days. The rates of major bleeding defined by both study and the TIMI criteria, including severe and fatal bleeding, did not differ significantly between two dose groups. But the rates of minor bleeding and the major GI bleeding were nominally significant in higher dose regime group. Now let's go through the clopidogrel and aspirin doses interaction for the primary outcome. The p-value for interaction was nominally significant for primary outcome. In high-dose aspirin cohort, a significant interaction was observed between the aspirin and clopidogrel with respect to primary outcome. A significant reduction in primary outcome was observed with a double-dose regime of clopidogrel. However, no such interaction was observed with low-dose aspirin cohort. Similarly, in double-dose clopidogrel cohort, a significant interaction was observed between aspirin and clopidogrel doses with respect to primary outcome, with significant reduction in primary outcome with higher dose aspirin regime. No such interaction was observed with standard dose clopidogrel. Now moving to subgroup analysis. In case of patients who underwent PCI, a significant interaction between PCI and clopidogrel was observed. In patients who underwent PCI, the primary outcome and definite stent thrombosis was significantly lower in patients under double dose regime compared to those under standard dose regime. Similarly, the trial-defined major bleeding was significantly higher in double dose regime compared to standard dose regime, while the TIMI-defined major bleeding did not differ significantly between two dose regimes. In case of non-PCI group, the primary outcome did not differ significantly between two dose groups. Now moving to the interaction between PCI and aspirin in case of patients who underwent PCI. In both PCI and non-PCI group, the primary outcome did not differ significantly between two dose groups, while the other outcomes like definite stent thrombosis and trial-defined major bleeding did not differ significantly between two dose groups. So there was no significant interaction was observed between PCI and aspirin group. Now moving to the subgroup analysis of patients presenting with STEMI who underwent PCI. The outcomes of stent thrombosis and myocardial infarction were significantly lower in double dose group compared to standard dose group, while other outcomes of cardiovascular death, stroke, trial-defined major bleeding, and trial-defined severe bleeding did not differ significantly between two groups. So in case of patients who underwent PCI, the nominally significant heterogeneity in the treatment effect of clopidogrel was observed with respect to primary outcome. But such heterogeneity in the treatment effect was not observed with aspirin. In addition, in PCI group, double dose regime of clopidogrel was associated with significant reduction in the rate of pre-specified secondary outcome of stent thrombosis. So now moving to the interpretation of trial. In overall cohort of patients presenting with acute coronary syndrome referred for early invasive strategy, high-dose clopidogrel and high-dose aspirin are not superior to standard dose clopidogrel and low-dose aspirin in reducing cardiovascular events at 30 days. However, a significant interaction between clopidogrel and PCI was observed in patients undergoing PCI with significant reduction in cardiovascular events, including stent thrombosis at 30 days was observed with double-dose clopidogrel. But this benefit is achieved at the expense of increasing the risk of major bleeding with high-dose clopidogrel. So now moving to the conclusion of the trial. In acute coronary syndrome patients undergoing PCI, double-dose clopidogrel for 7 days was associated with a reduction in cardiovascular events including stent thrombosis. Thus, double-dose clopidogrel regime can be used for all ACS patients referred for an early invasive strategy. The aspirin dose regimes did not differ from efficacy and safety point of view. So these are the references you can go through for the further details.